Good afternoon, and for our viewers on the West Coast, good morning. Welcome to the webcast. Just a little housekeeping before we get started. If you would like to enlarge the video screen, just click on the icon in the lower right corner. To ask a question during the webcast, please use the chat box on your screen. Questions will be answered at the end of the presentation. Today, Gnida from PRC will be presenting on the topic of CG-CAHPS. Jan is the Director of the Patient Experience and Government Surveys Departments and has been with PRC for 20 years. This presentation is the first in a 4-part CG-CAHPS series. Be sure to join us for all 4. And now, here's Jan.
Welcome, and thank you for joining me today for a look at CG-CAHPS and how it is used for accountable care organization measurement and physician quality reporting system measurement. This is the first in a 3-part series examining CG-CAHPS from several angles. The first thing I'll point out is that beyond that title slide, you're not going to see the term CG-CAHPS again in this presentation. CG-CAHPS, or Clinician and Group CAHPS, is the name of the core survey developed by the Agency for Healthcare Research and Quality, or AHRQ. The programs we're going to talk about today are built on that foundation, but they have their own more specific names. Today, our focus is on what's happening now, who is being required to use a version of the CG-CAHPS survey, and what's going to happen with those results. To begin, let's dive into the CAHPS for ACOs program. As many of you know, for the 2013 quality reporting, CMS conducted interviews on behalf of the Medicare Shared Savings Program participants. This took place in the early part of 2014, and those ACOs should be receiving a report of that data this fall. The biggest change for the 2014 measurement is that now, Medicare Shared Savings Program ACOs are required to contract with a CMS-approved vendor to collect the data. A list of approved vendors, including PRC, can be found at this website. PRC is proud to be included in this list and is looking forward to administering the survey for several new clients over the fall and winter of 2014. New this year, CMS is offering ACOs the choice between 2 versions of the CAHPS for ACOs survey. The full version that was used for the 2013 measurement, referred to as the ACO 12 version, contains 80 questions covering 12 categories and some patient demographics. A shorter version of the survey, the ACO 8 version, is comprised of 69 questions that cover the first 8 summary measures listed here, and the same patient demographic questions that are used for the ACO 12 version. Let's look for a minute at this list of 12 summary measures and talk about their origins. The CAHPS for ACOs survey is built upon the CG-CAHPS survey developed by AHRQ several years ago. Measures 1, 2, 3, and 8 are part of that CG-CAHPS core item set, so they must be included in any version of a CG-CAHPS survey. Measures 1 through 7 are the quality measures that will be evaluated by CMS to assess the performance of accountable care organizations. Measures 9 through 12 are questions that CMS believes are valuable for medical groups and practices to monitor, but these measures will not be included in the payment structure scoring at this time. So the ACO 8 version of the survey is the 7 quality measures that CMS will evaluate, plus the courteous and helpful office staff measure that belongs to the CG-CAHPS core. And the ACO 12 version is the whole shebang. The CMS has not offered a reason for why they're giving organizations a choice this year. I imagine it's a response to feedback from ACOs questioning the rationale for requiring the use of survey items that are not incorporated into quality scoring. The CAHPS for ACOs program measures Medicare beneficiaries only, and this slide summarizes the eligibility requirements. Looking at patient claims for the first 2 quarters of 2014, CMS will select a sample of 860 beneficiaries to be delivered to PRC. The data file transmitted to PRC will contain patient contact information, of course, and also the name of the ACO provider who saw the patient for the plurality of his or her visits. ACOs are not allowed to know which of their patients have been selected for the study. All in all, the sample selection process is pretty straightforward, and we expect to see a 50 to 60% total response rate. In other words, ACOs can expect to see about 450 to 550 completed interviews from PRC for this sample. With the file of selected patients delivered to the survey vendors, the work moves away from CMS and to PRC, your survey vendor partner. The activities and dates listed on this slide reflect the single methodology that CMS is allowing for this program. That is, a mixed methodology consisting of 2 attempts to contact the patient with a mail survey, followed by 6 telephone attempts. All in all, the data collection period will last about 2.5 months, with data files being submitted to CMS in mid-February. Now let's turn to talking about PQRS, the Physician Quality Reporting System. When we think about requirement and how CMS can make anyone do anything, it comes down to having leverage. And the CMS checkbook generates a lot of leverage. With the Medicare Shared Savings Program and accountable care organizations, CMS has a channel for requiring certain activities and measures by way of the contracts, so to speak, that they sign with those organizations. That was the first established and most obvious muscle that CMS could flex. But there are plenty of physicians and providers who provide care in the U.S. outside of that structure. How does CMS flex a muscle there? They're doing it through PQRS, truly one of my favorite acronyms ever. According to the CMS website, PQRS is a reporting program that uses a combination of incentive payments and payment adjustments to promote reporting of quality information by eligible professionals. Aha, we see that muscle flexing again. So let's take a look at how CMS is expanding the requirement for collecting data with the CAHPS for PQRS survey instrument. The requirements are defined in terms of the number of eligible professionals who bill under each tax ID number. We have 3 broad categories: Medicare physicians, practitioners, and also therapists. And then you can see there are a whole host of different individuals who fall into each of these categories. Your medical group's GPRO administrator or PQRS coordinator has probably already registered the eligible professionals with CMS, so that person would know exactly how many eligible professionals are considered as part of your group. That person would also know the specifics of your group's participation in PQRS. CAHPS for PQRS requirement began with data collection for 2013 for groups with 100 or more eligible professionals billing under the tax ID number. CMS administered the survey at no cost to those groups, and you'll notice that this continues for 2014. Yes, this year, CMS has contracted with the RAND Corporation to administer the CAHPS for PQRS survey, and groups of 100 or more eligible professionals won't have to do anything or pay anything to make this happen. We expect that for 2015, CMS will turn this work over to the survey vendors, like PRC. They will establish a vendor approval process, and groups will need to contract with and pay an approved vendor to do the surveys for them next year. Now let's look at the next segment of medical groups, those with 25 to 99 eligible professionals in the tax ID number. Measurement is optional this year for those groups, and if your group chooses to participate, CMS will also take care of all administration and costs for 2014. I believe that you register your choice to participate or not through the GPRO web interface, and I think the window for selecting this option will be closing very soon. For these groups, surveying will be optional again in 2015, but the difference will be that you'll have to use an approved survey vendor next year, and you will have to pay for the data collection. The last segment to be incorporated are the groups with 2 to 24 eligible professionals. For these smallest groups, they may first exercise the option to administer the surveys in 2015, and if they do, they'll need to work with an approved vendor for that to happen. It doesn't appear at this time that CMS will administer a first year of data collection for these groups as they did for the larger groups. Again, 2015 will be optional. We have not seen yet when measurement will be required for the groups in the 2 to 24 range, or the groups in the 25 to 99 range for that matter. Chances are good that it will be within the next 2 to 4 years. This survey list should look very familiar to you. The CAHPS for PQRS survey is identical to the ACO 12 survey version, with the same questions, same reporting dimensions, same patient demographics. The CAHPS for ACOs and CAHPS for PQRS programs have been following parallel tracks. We see that in the survey instruments, and we expect to see it in the sampling and data collection protocols when those are announced for PQRS. To my knowledge, CMS is fielding the full 80-question survey this year for the groups of 100 or more. They don't have the option to use the shorter version that's available for the ACOs. We expected that CMS would turn the CAHPS for PQRS work over to survey vendors for 2014, and we're surprised to see that they chose not to. I suspect that they felt another year of survey administration by a single company, again the RAND Corporation, would be helpful to finalize the rules and develop the quality assurance guidelines that we expect to be issued next year along with the vendor approval process. We'll be watching for that, of course, and we'll share information as we have it. So CMS is collecting this information about physicians and providers and medical groups on two fronts. What are they going to do with it? We know financial incentives are built into the ACO contracts, and the next webcast on October 2nd will examine the PQRS value modifier for reimbursements. CMS's other need for this data is public reporting. CMS established the Physician Compare website, seen here, as a resource where Medicare beneficiaries and consumers in general can look at information about providers and use this information to make informed decisions about where and from whom they seek health care. You can see that presently, the page indicates that this physician participates in PQRS, but that's all we know. The page does not currently provide any specifics about Dr. Wilson's performance on those measures. I've included this slide, which was shared during a CMS-sponsored national provider call, and it refers to group-level reporting and individual physician-level reporting. Note that the CAHPS for ACOs and PQRS results will be only reported at the group level. No scores for individual physicians from the survey will be published on Physician Compare, which makes sense when you think about the sampling and the number of completed interviews we expect to see. There simply won't be enough data to share reliable physician scores with the current study design. CMS may move toward that objective in the future, but we're not there now. At this point in time, only scores for your medical group as a whole will be included on Physician Compare. For more information from this national provider call, please see the address noted on the slide. Later this year, we look forward to seeing the first results from the 2013 quality reporting period, available on Physician Compare. Data will be coming from both the ACO and PQRS measurement programs. The first results will be 6 scores, measures 1 through 6 listed on the slide. You'll recall that these 7 measures are the ones to be evaluated for ACO performance. CMS has chosen to not report the health and functional status measure at this time. We will see 6 scores for your group on Physician Compare in the coming months. Before we take questions, I have one final suggestion for you. You may recall when I was talking earlier about the number of eligible professionals under a tax ID number, and I mentioned the GPRO administrator or PQRS coordinator. If I was talking about you, then thank you so much for joining us today. I imagine that the world of patient experience measurement may be new to you, and we really appreciate you taking the time to learn more about it, understanding that it's going to have a greater presence in your work going forward. If I was not talking to you, I hope you know the name of the person I'm talking about. If you don't, then I strongly encourage you to go and find this person. I've talked to patient experience people from a number of medical groups over the last 6 months who didn't know who this person was. This person, the GPRO administrator or PQRS coordinator, or perhaps the person who performs those functions has another title within your group, this person is going to be a valuable source of information for you as it relates to your group interacting with CMS. Just as you are going to be a valuable resource to her or him as it relates to your group interacting with an approved survey vendor like PRC. Through programs like ACO and PQRS, CMS is bringing clinical quality and patient experience together, and a strong working relationship will help your group succeed. If you haven't started already, start building that relationship now. So there you have it, Nancy. Now, what questions have we received from the audience?
Thank you, Jan. That was great.
Thanks, Nancy.
Just a few reminders before we go into the questions. If you do have a question, you can type it into the chat box that you'll see on your screen, and then those will come in and I'll be able to see them here on my iPad, and then we'll ask Jan and she'll get them answered. A couple of people have already asked for the PowerPoint slides, and we always send those out after every webcast, so be on the lookout for those. And just remember that this is the first in a series of these CG-CAHPS webcasts, so make sure that you check out the ones that are coming up as well. So we do have a few questions already. The first question, Jan, for you is, the CG-CAHPS surveys have a lot of questions. Mm-hmm. Do we have to worry that people won't complete the survey?
I don't think so. You know, what we saw when we fielded this survey before is that while, yes, it does have a lot of questions, it does take more time on the telephone than our typical surveys, we're not seeing evidence of people bailing out before they get to the end because the survey is too long or anything like that. So I don't think it's a concern for people not participating.
Okay. Our next question. At one point you had mentioned that CMS is pulling the sample, I think, for the ACOs. Yeah. Why are they doing that?
Yes. This is something that's different about the ACO program than, you know, the HCAHPS program or home health, where hospitals or home health agencies are sending the files directly to us and we pull the sample. For the CAHPS for ACOs program, and we anticipate that this will be the case for the CAHPS for PQRS program as well, CMS is drawing that sample from the claims data that we've received. And I think the primary reason for doing that is just reducing variability. CMS can control what they're doing themselves, and so that's a component of the data collection process that they don't have to worry about making sure that all vendors are doing the same way because they're taking care of it for everybody. So it makes oversight a lot easier for CMS to do it themselves.
Great. Our next question here, what has been PRC's experience with these studies?
Sure, yeah. Last year, for the 2013 measurement, only the Pioneer ACO programs were required to use a survey vendor for that. So there were about 30 Pioneer ACOs at that time, and PRC did the data collection for one of them. For the 2014 measurement that we're just getting ready to start now, now we know all of the Medicare Shared Savings programs are looking for a survey vendor, and PRC has a little over 40 ACOs that we'll be working with. As I mentioned, the PQRS program has not been turned over yet to the survey vendors, but we'll expect to be doing that next year. And as I mentioned, I think the protocols and the data collection methodology for PQRS is going to be very, very similar to what we're doing for the ACOs.
And a question that kind of goes along with that we just got here. Will all vendors have to follow the same methodology?
Yes. For the ACO program, there is one methodology that is allowed, so it's not picking and choosing. Everybody will be doing the 2 paper surveys through the mail, followed up by the 6 telephone attempts for people that don't respond to the mail survey. Everybody will be doing the same thing. And again, I think that's an effort on CMS to reduce variability in what's happening with everyone's data collection, and it makes the oversight easier for them.
Great. And here's kind of a silly question. How many acronyms did you say in this podcast?
I've not counted them up yet, but if anybody wants to count between this and the other ones in this webcast, I'm guessing that it's probably somewhere in the 80 to 100 range.
Wow.
I was, yes, a lot of letters going on here.
Will PQRS be tied to reimbursement?
Yes. This is less straightforward than for the ACO program, than maybe for, HCAHPS, if you even want to think about that. There are some reimbursement impact for PQRS right now for those large medical groups, but it's simply are you doing it or not? And if you're doing it, you're getting your full reimbursement. The next webinar in this series, the next webcast that will be on Thursday of this week, we're going to look specifically at the value modifier. This is the VBP parallel for physician practices. We'll be looking at the value modifier and how that's built on the PQRS program, and we'll be talking about the percentages of possible penalty and gain that are going to be available through that program. So join me for that on Thursday.
Okay. And someone did ask about the availability of this webcast later, and it will be available. I will send out a link to all of our registrants for this particular webcast so that you can watch it at a later date. So be on the lookout for that link. I will also be sending you the slides, so be on the lookout for those as well. Okay, our next question. This kind of goes back to the question about all vendors following the same methodology. With all vendors using the same methodology, will there be any weighting of the data?
Yes and no. There is a lot of math that goes into the final ACO reports. We saw last year from the Pioneer ACO that we worked with. It's in some ways similar to what we've seen for HCAHPS. There's not a mode adjustment, of course, because everybody's got the same mode, but there are some adjustments for patient mix. CMS, if you recall on that slide about eligibility, CMS is oversampling to a small degree we'll call them the heavy users, the patients who've had more visits, and so they'll need to make an adjustment in the data for that. I think there's also some type of adjustment being applied for response lag, in how much time did it take the person to respond to the survey, that sort of thing. So the bottom line is that there's a lot of math that CMS is doing with all of this data after data collection is complete. Since it hasn't been publicly reported yet, we haven't been able to compare raw scores to publicly reported scores or to final scores to really understand the degree to which those numbers are adjusted. I'm hoping that that's information that we'll be able to glean later this year when we start seeing results reported on Physician Compare. In addition, I hope that CMS will start giving us more information, or more specific information, maybe more instructions, so to speak, about how they're doing that weighting so that we can share that with people.
Okay, great. And then, Jan, if people wanted to contact you with additional information that maybe they didn't ask a question here, what would be the best way for them to get a hold of you?
That's a great question. Lots of people have that question. The best way, honestly, is email, and my email address and phone number are on that last slide there. You can also go through your PRC Client Relationship Manager. A lot of these questions they may be able to answer for you. If not, we can certainly schedule a time to talk. I have a great team of people that I work with to take care of all of the CAHPS work for our clients. Laura Van Epps, I'm sure many of you have heard from as well. She has access to my emails too, so a lot of times you may send something to me and she may be the person that responds as well. Email is probably the easiest way to reach me.
Okay, great. We have another question that came in. You had mentioned that the ACOs can do a short version and a long version of the survey. What would you recommend?
That's an interesting question. I think that it really depends on what you want to get out of that data. The difference in survey length is not significant enough that it's going to impact people responding, like we talked about before. So it's really a matter of if you think that additional information, if those additional questions are going to be of interest to you. I would encourage you to, take a look at those questions and decide, are these things that we think we have problems with? We'd like some more data. Is there anything in here that we think, there's somebody who has a particular interest in that topic, in that aspect of care? But if you don't think you're going to use that additional information, then I don't think it's necessary to ask those questions.
Okay, great. Well, thank you, Jan.
Thank you.
Great webcast today. And thank you all for joining us today. And just as a reminder, just in case you didn't hear me the first time, we are going to be sending out, or I guess I will be sending out the PowerPoint, as well as a link for you to be able to watch this webcast again at your own leisure. So thank you again. Hopefully we'll see you on Thursday. Or Thursday, excuse me. Today is Tuesday. On Thursday.
Thanks.